Thank you all for logging on and welcome to today's DHIN webinar, which is called Musculoskeletal Pain and the Adoption of New Technologies in Care and is presented by Associate Professors Paulo and Manuela Ferreira. Manuela and Paulo are both former physiotherapists and now University of Sydney HNMRC Research Fellows in back pain. They are also both Sydney University SOAR Fellows. Manuela's focus is on surgical management of low back pain, and Paulo is interested in how lifestyle factors can be adapted to prevent and treat back pain. Manuela and Paulo are also co-leads of the musculoskeletal pain node within the DHIN. A resources pack will be sent out at the end of the webinar with full bios and a link to the website and a recording of this webinar. My name is Jacqueline Wells and I manage the Digital Health and Informatics Network, which brings this webinar to you today as part of our new webinar series in digital health. Before we start the presentation, if you could please note the following housekeeping information. Paulo and Manuela will present their talk and welcome your questions throughout. Please type your question into the questions box in the GoToWebinar control panel and press send to all. Paulo and Manuela will answer your questions at the end of the session. And if we could just check if this is working, please, would someone just mind typing hello into that box? Thank you. After the webinar, a short survey with 5 questions will appear on your computer screen. We very much appreciate the time you spend to complete the survey as your feedback informs and shapes future events. Thank you, everyone, and I will now hand over the presentation to Manuela and Paulo.
Thank you, Jackie, and welcome to this webinar. We're all very excited about the opportunity to discuss some of the issues related to digital technology and people who suffer from musculoskeletal pain and how the technology and the approach can help those people in need. So I'll start with a brief discussion about how and why we're setting up some research around digital technology in musculoskeletal pain, and I'll try to provide some of the examples of how the approach can be useful in people with chronic musculoskeletal pain, some of the research that we've been doing, and then I'll pass it on to Manuela as well, who will continue with this presentation. So I thought that we should just start by providing a little bit of a picture of how important and significant musculoskeletal pain can be. And the example that we are using here is back pain, which is the most prevalent type of musculoskeletal pain. A lot of people think that pain in your back is just a usual symptom, but in reality, back pain, and especially chronic low back pain, can be highly associated with high levels of disability. You can probably see on this slide here that when we look at the number of years lived with disability, low back pain ranks the top condition globally and also in Australia as well. So it's a highly significant problem that we need to help, and that's when digital technology can be useful. It also costs a lot to government and society. Back pain, for example, affects around 4 million people in Australia at any given time, and it is estimated that the total annual costs can be as high as 5 billion. The problem is that musculoskeletal pain is likely to get worse with time. You can probably see on this graph here that the prevalence estimates of osteoarthritis and other musculoskeletal conditions are going to climb in the next few years. So we all need to join forces to try to help to solve this problem. People who have chronic low back pain are likely to be on high dose of medication. A small percentage of people are on opioids and other narcotic analgesics. This is just some data from the US showing that this is a tendency that is quite scary and worry. In Australia, this might not be such a big issue, but we still have quite a lot of people on NSAIDs and other types of medication. And the problem is that some of these medications are not helping much people with musculoskeletal pain. So this is just some data from previous work that we have done with our PhD students. And you don't need to be an expert in meta-analysis to see that most of the effects of paracetamol, for example, is very close to a non-significant effect. And that includes for back pain and osteoarthritis as well. So very common type of medication that doesn't appear to be offering much. A lot of treatments for low back pain. This is just a graph showing the variety of treatments that we have. And again, this is a vertical line showing the zero effect. And we'll see that a lot of these treatments that have been used for back pain are actually crossing that line. So lots of treatments available, but some of them, or perhaps most of them, don't have a huge and significant clinical effect for patients. Even when we see some effect, sometimes patients decline over time. So I just want to point this graph to you and show you that these are actually results of a previous randomized controlled trial that we've done of exercise for chronic low back pain, and we see this big improvement with treatment. Once treatment finished, we see this is low and sort of constant decline in clinical symptoms over time. So we probably need to help people somewhere in this pathway of their disease as well. And again, that's when digital technology perhaps can be useful. So I'll just provide a few examples of how digital technology can help those patients. And the first sort of broad overall example that I would like to discuss is how digital technology can help to reduce care seeking in musculoskeletal pain. Care seeking is a major issue for people with, particularly with low back pain, and we want to help these people to reduce unnecessary treatment if we can. Coming back to this graph, as you probably saw in the previous slide, we want to help people to not be exposed to this clinical decline and seek extra care. We think that if patients go through this clinical decline, particularly in pain and function, they'll probably have flare-ups in their condition and they will seek additional care. So we currently have just finalized the pilot stage of a study to use mobile health intervention with the addition of a health coaching approach to help those patients here to become more physically active and perhaps reduce the risk of flare-ups and not need to seek additional care. So that's just an example of an e-health type of study and intervention that we currently have in place. I'm just showing you here some print screens of how we collect the baseline data from our participants using an online type of platform. And the whole intervention was delivered using an app that we designed for this study. It's called the Impact Spinal Health, the Impact Study. So basically what we had with this study was, with the support of this app that we designed, and we had a clinician, a health coach interacting with patients and helping them to set up some physical activity related goals. And every time the patient would come and achieve a particular goal, he would receive some positive feedback. And again, we collect data using this web application as well. So the whole program and the data collection system was implemented online. Just quickly showing some of the preliminary results. We had people randomized to the mobile health group and people in the standard care group. They seem to be similar in terms of pain and disability at baseline. And this is just a graph showing that those participants randomized in the physical activity group, in the mobile health physical activity group, they had 38% reduced rate of seeking additional care after they were discharged from treatment. This is the result of the pilot stage of our study. We're not fully powered to test all these effects, so the difference here was not statistically significant. But we believe that needs to be followed up in a full powered clinical trial because the effects appear to be considerable. Again, we kept looking, monitoring these patients, and as we can see, with time, the intervention appeared to reduce more and more care seeking compared to the control group. So basically what this is showing is that as we implement that mobile health physical activity intervention, it appears to increase its effectiveness over time compared to the standard care group. The other example that I would like to share with you is how digital technology can help to increase access for treatment and proper care in those patients who suffer from musculoskeletal pain and cannot access proper care. And the example that I'll bring to you is a current project that we are setting up in rural Australia to try to help those communities who live in remote areas to get proper care for their musculoskeletal pain. The biggest problem that we have in those communities is that patients are more likely to experience low back pain. They're more likely to have high rates of knee replacement for their knee osteoarthritis. They wait longer to access pain clinics, and they also appear to be more sedentary compared to those in urban settings. So a lot of people think that if you live in a farm or if you live in a rural setting in Australia, you are more physically active, but in reality, that doesn't appear to be the case according to the results of our research. These people, they need to travel long distance to access care, and it appears that distance travel is responsible for a high financial burden for society in general. Those who are in major cities, they have more access to physios, for example. So in major cities, we have an average of 117 registered physios for every 100,000 people. But those who live in regional and remote Australia, the density of clinicians is definitely much less. It's only around 50%. So we have set up what we call the Empower project, which is a project that we are implementing in Western New South Wales to try to determine the effectiveness of a mobile health intervention, which involves physical activity, exercise programs compared to usual care. And our target population are those with chronic low back pain and knee osteoarthritis in rural and remote Australia. Just a quick overview of the design of our project. We are at the stage of implementing data collection. We have just received ethics application for this. We will basically compare a knee health intervention, which will be tailored physiotherapy plan delivered remotely compared to a usual care intervention. And we follow these people for up to 1 year. Just a print screen of how the intervention will look like. So people will log in remotely using their computer or their tablets or their phones, and they will receive physiotherapy consultations. And those consultations will involve a home exercise program and a physical activity plan and an online pain coping skills program as well. So we'll try to help those people with back pain in the way to manage their conditions remotely. The third example that I would like to share with you is how perhaps the approach can help improve sleep quality in those who suffer from musculoskeletal pain. Perhaps you are aware that sleep is a major issue in musculoskeletal pain. Those who have poor sleep quality, they have more chance of developing higher levels of pain in the future. So sleep is a major issue in musculoskeletal pain. So we have set up an online web-based type of intervention and digital study to look at the efficacy of an online sleep program to help those people who have low back pain and poor quality sleep to improve their sleep. So it's a good example of how a digital technology type of program and study can test the efficacy of this intervention compared to a control group to improve sleep quality and check the impact of that into musculoskeletal pain. So I'll just share some of the results that we have so far. We haven't done a full analysis on this study yet. So what you're seeing here is the pattern of response for different types of outcomes. You have the control group and the digital technology mobile health sleep group in orange. It looks like from our preliminary analysis, there is not a lot of change in the pattern of sleep. We're still collecting the long-term follow-up. It looks like there is not a huge effect for disability levels. What appears to be happening is perhaps an improvement in the intensity of low back pain, and that's what we see here. In this particular graph, with those randomized to the mobile health intervention having less intensity of symptoms at follow-up, and they appear to be managing their pain a little bit better when we look at the self-efficacy as well, with this difference appearing to be statistically significant. But there is more to come on this particular study. So I'll just pass on to Manuela now, who will keep keep up with the discussions.
Thank you, Paulo. Thank you, Jacqueline. And hello to all the webinar listeners. So as Paulo mentioned, the adoption of technology in healthcare has the potential to address some major issues in healthcare, not only in Australia, but globally. Some of the examples being healthcare workforce shortages, poor access, like Paulo said, either because of remoteness or because of disabling conditions such as back pain, preventing people to travel, for example, more than 30 minutes in a car because the condition will get worse. Limited resources, limited provision of preventative strategies. So these are some of the issues that can actually be addressed with technology. Now, technology in healthcare can also take a range of formats. So it can be used to deliver an intervention. It can be used to monitor treatment adherence. It can be used to monitor symptoms. It can be used to enhance engagement with care, such as video games, and I'll very briefly talk about one of our examples in that space. It can be used also as an interactive source of information and education, and because of that, to enhance shared decision making. So some of the examples are websites, apps, and it can be used to support user communities, and that includes clinicians and patients. So let's just very briefly talk about the evidence. So is there any evidence that the use of technology will actually achieve those benefits? So there is a range of studies, RCT, systematic reviews, cohort studies out there of varying quality. So we have to be aware of that. So this is a very, very brief overview of the main benefits of technology-related interventions for for all conditions. So technology has actually been shown to significantly increase adherence to guideline-based care. So there was a large systematic review showing and establishing that in chronic conditions in general. Technology also has a potential to increase adherence to healthy lifestyle behavior and medication, specifically mobile health interventions, so via apps and text messages. Enhance surveillance and monitoring, so it has been shown to actually achieve that. Decrease medication errors, improve preventative health. One of the main observed efficiencies of technology in healthcare is actually the decrease of, like Paulo said, unnecessary use of healthcare. And we found a number of studies in some isolated conditions. So, for example, technology has been shown to improve provision of education and disease monitoring in cardiovascular disease with the current 12 systematic reviews, and diabetes with 8 systematic reviews. Mobile health has also been shown to increase patient engagement or consumer engagement with both the clinician and the intervention. And it has been shown to be a credible and valuable resource by consumers in general. More specifically in musculoskeletal health, and I should highlight that these are the positive. I've just highlighted the positive studies, or the benefits. So there is also a range of studies showing no benefit in other areas, but we have observed, and that was through a systematic review done by our group, that real-time biofeedback, such as the WeFit and the Connect, can actually provide significant gains in mobility, post-joint replacement, spine movement retraining using motion sensor biofeedback, such as the vMove, can actually improve pain and disability in chronic back pain. Wearable devices, such as the Fitbit, can actually result in increased participation in physical activity by 20% in people with OA and low back pain. We all know that lack of physical activity in this population is a major issue, and it is associated with the development of a number of other very important comorbidities, such as cardiovascular disease. So this is a major benefit. And technology can also, through remote delivery of exercises via Skype, can also improve pain and function in people with knee OA. So we talked about this a little bit, but there is a recent systematic review on the adoption of video games in rehabilitation for all conditions. They included 126 clinical studies, so cohort studies and RCTs, since 2008, when the first study was actually published. Of those, around 21 were conducted, were randomized controlled trials conducted in older people. One of my main interests in research is actually aging and back pain, or aging and musculoskeletal pain. So that was something that I was very much interested in. So in general, what the systematic review showed was that video game-based exercise delivered at an average of 3 times a week for 8 weeks can actually significantly improve balance, endurance, physical activity, and feelings of depression, mobility, and quality of life. So now just briefly, just to close, a few examples of projects that we are doing in that space. So the first one is the Text from My Back trial. The Text from My Back trial is a use of technology to empower self-management in people with back pain. So we all know that self-management has the potential to play a major role in the care of back pain. It does in other chronic conditions such as diabetes, heart disease, pulmonary disease. But we also know that to be effective, a self-management program needs to have some patient support, needs to involve education of consumers / patients. And again, to be effective, there needs to be some level of monitoring. Effective self-management approaches can actually decrease the burden and prevent chronic state of any disease. In back pain, there is a lack of self-management approaches that can actually usefully and effectively be implemented in care. So we've actually partnered with the TextMe group. So these are researchers from Sydney University, and the TextMe trial established in 2015, established the effectiveness of a text message-based intervention to encourage change in diet, physical activity, and smoking in people with cardiovascular disease. The intervention was shown to again increase adherence to healthy lifestyle behavior, adherence to medication, was cost-effective, highly valued and by patients, and there was a very high patient engagement. And of course, they showed very positive and significant effects in the decrease of cardiovascular events. So in partnership with that group and also with the School of Pharmacy here at Sydney University, we have designed the Text from My Back trial. The Text from My Back will recruit around 300 patients with back pain presenting to participating pharmacists, and they'll be randomized to either a text message-based intervention, text messages being delivered 4 times a week for 3 months, or a one-off information package. The text messages will be delivered in different domains addressing, again, education, use of care, physical activity, and diet, sleep. Another example of use of technology is the Back in the Game trial. So the Back in the Game trial is still in the very early stages, but the idea is that we'll use technology to improve access and adherence to exercises in older people with back pain. So it's a video game exercise type of intervention for older people with low back pain who live in residential care facilities. We know that older people with back pain suffer from more disabling and severe pain. They are very often and largely excluded from randomized controlled trials. They do have limited access to exercises, and adherence in general to exercise and physical activity is low. So that's where the video games and the technology comes in handy. So the aim of this trial will be to evaluate the effectiveness of video game-based exercise program compared to usual care to improve function and mobility in older people with back pain living in residential care facilities. So again, this is in the very early stage. But we hope to be recruiting patients in the very near future. And the last example is actually the use of technology to assist post-surgical care in musculoskeletal pain. So we know that around 80,000 elective surgeries are performed for knee, OA, and back pain every year in Australia, costing over $6 billion a year. And we also know that there is evidence that telerehabilitation can actually increase patient adherence and decrease costs in that scenario. So we are proposing a participatory health through behavior engagement and digital technology for post-surgical rehabilitation. It's a long title, but it's a very exciting project. So the idea is that technology will be added to post-surgical care and compared to post-surgical care alone in people having knee replacements and lumbar spine laminectomies. We'll monitor movement, both of the spine and of the knee, so joint range of motion. We'll also monitor activity, physical activity, and there will be a health coaching component to actually assist patients in achieving their goals in those domains. So everyone will be assessed at baseline and 3, 6, and 12 months, and we'll be measuring mobility and symptoms, quality of care, adherence to treatment, and there will be a cost effectiveness analysis at the end of the trial. So just quickly moving forward, the idea was to present some of the examples of how and when technology can be used in the care of musculoskeletal pain. We have to remember that the current stage of technology in musculoskeletal pain is actually fragmented. So there are a lot of proposals, a lot of different proposed technologies and intervention or technology-based interventions for the care of musculoskeletal pain, with not as much evaluation. So the idea is that we really reinforce the need and the importance for a robust and well-structured evaluation of the technology that is available out there. Appropriateness and acceptability, especially from the consumer point of view, is key. So all of the projects that we are now developing and proposing start with a very strong consultation with clinicians and patients, because without acceptability, there will be no implementation. So I think I should stop now, otherwise there will be no time for questions, and I'll pass on to Jacqueline.
Thank you very much, Manuela and Paulo. That was excellent. Just wondering if we've got any questions today. If you'd like to type it into the question panel and to send to all, please. I've got one for you, Paulo. You mentioned when you were talking about the University of Sydney study that you were doing with the apps, you said that people get rewards. Is that correct when they feedback? Is that right? So how does that work?
Yeah. So for this particular study, the app that we designed, it has the capability for the health coach to send some feedback whenever the patient achieves those goals. So the feedback that we currently have is still very simple in nature, but it's just in the form of a simple text that the patient sees on the app when that particular goal is achieved. So the goals are discussed mutually, and if the patient agrees that a particular physical activity related goal is an important one. So for example, walking walking for 20 minutes every day, and that's that patient's goals. And then what happens is that at the end of that week, with the data that the patient inputs into the app, the health coach can access that, and if the goal is achieved, then that's when the feedback comes, and it comes in the form of a simple text. If the goal is not achieved, then the health coach can also feed that back to the patient as well in a nice and motivating way, and perhaps letting the patient know that although that goal was not achieved, maybe some of it partially was achieved, and then they can progress towards a different and new goal.
And Manuela, you mentioned too about the back in the game, and that's with older Australians, is that right? So how do you think that older Australians will take up that sort of gamification? Is that an issue, do you think, or a barrier?
Yeah, so it is with older Australians, and the answer would be no. So there is pilot studies showing that the adherence is greater when we use games. They really enjoy it. It's a safe approach, and it is associated with important decreases in pain and increase in function. So yeah, we believe there will be actually a large uptake. Yeah.
Does anyone have any questions? Any questions? Thank you. So I just wanted to say a massive thank you to Manuela and Paulo for today. Today's session marked the second webinar in the DHIN webinar series, and today's talk has been a really engaging presentation, so thank you both very much. Musculoskeletal pain is a node within the DHIN, and we encourage you to sign up if you're interested in knowing more about what was covered today. We send out communications normally about once a month, and I know that there are some really interesting things happening in the musculoskeletal pain over the coming year. As I previously mentioned, we will send around a resources pack with the full bios of Manuela and Paulo, the presentation and a link to the recording, and this will be posted in the next 48 hours. So thank you to everyone for attending today and hope you have a lovely day. Thank you.